Okay, so ready to dive into a procedure that's like routine now, but was once thought to be impossible.
Yeah.
Today, we're going to be looking at one lung ventilation,
Uh-huh.
the art of breathing with, just one lung in the world of thoracic anesthesia. We've got lectures from Dr. MEK, a mock exam scenario from ABCs of anesthesia. And let me tell you, some of this stuff will have you looking at breathing in a whole new light.
It's wild to think about, right?
Yeah,
Open chest surgery was basically a death sentence not that long ago.
totally.
Yeah.
Our sources paint a pretty intense picture. Before we had modern anesthesia, cracking open the chest was like game over.
It's true.
Lungs would collapse and you'd have this thing called paradoxical breathing.
Yeah.
Imagine your lungs inflating when they should be deflating and vice versa.
Oh, yeah.
Talk about a system error.
The human body is resilient.
Yeah.
But it can only handle so much.
Yeah.
This is why the invention of the endotracheal tube with an inflatable cuff back in 1928 was a total game changer.
Right. Like the invention of sliced bread, but for lungs. It's incredible to think that just a few years after this invention, the first pneumonectomy, that's the removal of an entire lung, was successfully performed.
It really highlights how one innovation can unlock a whole new world of possibilities. This wasn't just about keeping someone breathing during chest surgery. It opened the door to complex thoracic surgeries that were previously unimaginable.
Okay, so that brings us to one lung ventilation, or OLV, as it's known in the biz. Now, why go through all this trouble to breathe with only one lung during surgery? It seems counterintuitive, right?
It's all about creating the best possible environment for the surgeon. Imagine trying to work on a moving, breathing lung.
Yeah.
By deflating the lung on the side of the operation, you give the surgeon a clear, still surgical field. This not only improves access, but also prevents contamination from things like blood or pus spreading to the healthy lung.
So it's like creating a controlled deflation to make the surgeon's job easier and safer.
Exactly. And let's not forget about protecting the healthy lung. Stray instruments, surgical debris, you name it, it's a risk during these delicate procedures. Deflating the lung creates a protective barrier.
That makes a lot of sense. Now, how do you even go about breathing with only one lung? Our sources mention two main techniques: double lumen tubes, or DLTs, and bronchial blockers.
DLTs are considered the gold standard.
Okay.
Think of them as high-tech breathing tubes with two separate channels, one for each lung.
Okay.
One channel goes down the trachea, providing ventilation to both lungs initially. The other channel is strategically positioned to target just one lung, allowing for independent control of ventilation.
Okay, so you've basically got a 2-for-1 deal going on with this DLT, but why is this dual-channel design so important?
It all comes down to control and precision. With a DLT, the anesthesiologist can independently ventilate each lung or completely deflate one while keeping the other inflated, which is exactly what we need for thoracic surgery. This level of control is crucial for maintaining optimal oxygenation and minimizing complications.
So it's like having a separate air supply for each lung.
Yeah.
That's seriously impressive. But Dr. MEK's lecture had some surprising insights about DLTs. Apparently, size matters, and bigger isn't always worse.
That's right. It's a common misconception that a smaller tube is always less traumatic. While that's true for general intubation, when it comes to DLTs, going too small can actually be more dangerous.
Wait, really? Why is that?
A DLT that's too small for the airway can cause increased resistance to airflow, making it harder to ventilate the lungs effectively. Imagine trying to drink a thick milkshake through a tiny straw. It's going to be a struggle. Plus, a tight-fitting DLT can put pressure on the delicate tissues of the airway, potentially causing damage.
So it's about finding that Goldilocks size, not too big, not too small, but just right for the individual patient's anatomy.
Exactly. And thankfully, there's a handy formula to guide that decision-making process. 12 plus 0.1 times the patient's height in centimeters. This calculation provides a good starting point for estimating the appropriate DLT depth, which, like most things in medicine, can vary from person to person.
So this formula isn't a one-size-fits-all solution.
Not at all. It's just the first step in a very meticulous process. Anesthesiologists use this initial estimate and then factor in things like the patient's build, chest size, and any pre-existing medical conditions that might affect their airway.
So it's like tailoring a suit. You need the right measurements and adjustments for the perfect fit.
Precisely. And once you have that estimated size, the placement process is just as crucial. It's a delicate dance of precision and vigilance. Anesthesiologists use a combination of visual cues from the breathing tube, careful listening to breath sounds with a stethoscope, and even real-time X-ray imaging to ensure the DLT is positioned correctly.
That's a lot of checks and balances. I guess there's no room for error when you're talking about something as essential as breathing.
You got it.
Right.
We want to be absolutely certain that the targeted lung is properly isolated and the healthy lung is protected before surgery even begins.
It's amazing how much goes into ensuring proper DLT placement.
Right.
It's definitely not as simple as it sounds. But what about those times when a DLT just isn't an option? That's where bronchial blockers come in, right?
Right. They're like the understudies of the OLV world, always ready to step in when a DLT isn't feasible.
Oh, okay.
These are thin, flexible tubes with a balloon on the end that can be guided through the trachea and into the bronchus of the lung that needs to be deflated.
So instead of having a tube with two separate channels, you're strategically blocking the airway to one lung with this, like, tiny balloon.
Exactly. And just like with DLTs, the placement of these blockers is crucial. Anesthesiologists use bronchoscopes, which are thin, flexible tubes with cameras on the end, to visually guide the placement of the blocker and ensure it's in the right spot.
So it sounds like anesthesiologists need to have, like, a deep understanding of anatomy and a surgeon's precision to navigate these airways effectively.
Absolutely. It's a highly specialized skill set that requires extensive training and experience. But let's shift gears for a moment and talk about what happens once the patient is prepped, the chosen airway device is in place, and surgery is underway. This is where the anesthesiologist's role becomes even more critical.
Right, because now they're responsible for maintaining the patient's, like, life support with only one lung doing, all the work.
Exactly. It's a delicate balancing act that requires constant vigilance and a deep understanding of respiratory physiology.
I bet. So what are the, the top priorities for the anesthesiologist during this crucial phase?
Oxygenation is key. We're working with half the lung capacity, so we need to ensure the patient is getting enough oxygen to meet their body's needs. This is why anesthesiologists typically use 100% oxygen concentration during these procedures.
So instead of the regular air we breathe, which is about 21% oxygen, you're giving the patient a pure oxygen cocktail.
That's a great way to put it. By maximizing the oxygen content in each breath, we're giving the working lung the best possible chance to keep the body supplied with this vital gas.
Makes sense. But it's not just about cranking up the oxygen dial, right?
Right. We also have to carefully adjust the tidal volume, that's the amount of air delivered with each breath, and the respiratory rate to maintain optimal oxygen levels without putting too much pressure on the working lung. It's like finding the sweet spot on a dimmer switch where you have enough light without, blowing a fuse.
Okay, so it's a careful balancing act. Too much pressure and you risk damaging the one lung that's, like, working overtime.
Exactly. And on top of that, we're constantly on the lookout for hypoxia, which is a condition where the body's tissues aren't getting enough oxygen.
That sounds serious. What are some of the things that can cause hypoxia during OLV?
Well, a common assumption is that it's always due to a misplaced DLT or bronchial blocker. While that's a possibility, it's not the only culprit. You see, even with perfect placement, the body doesn't always adapt to one lung ventilation as smoothly as we'd like.
What do you mean?
Think about it.
Yeah.
Our bodies are designed to have both lungs working in sync.
Yeah.
Blood flow in the lungs is naturally directed to areas that have the most oxygen.
Yeah.
But when we collapse one lung, some blood continues to flow to that non-ventilated side, even though there's no oxygen to pick up.
Oh, wow.
This is called shunting, and it can lead to hypoxia.
So even if the ventilator is doing its job and delivering oxygen to the working lung, the blood flow might not cooperate.
Yeah.
And some blood might, bypass the oxygen entirely.
That's right. And this is where positioning becomes crucial. By carefully positioning the patient on their side with the operative lung, the one that's collapsed facing up, we could use gravity to our advantage.
How does that work?
Gravity naturally pulls blood downwards. By having the working lung positioned lower, we encourage more blood flow to that lung, where it can pick up oxygen effectively.
So you're using the patient's own body weight to, help optimize blood flow and improve oxygenation. That's pretty clever.
It's one of those, low-tech solutions that can make a big difference. But sometimes we need a little extra help. That's where CPAP comes in.
CPAP, like the machines used for sleep apnea?
The very same.
Oh, wow.
CPAP, which stands for Continuous Positive Airway Pressure, can also be used strategically during OLV to improve oxygenation.
How does that work in this scenario?
Imagine a gentle breeze keeping a balloon slightly inflated.
Okay, yeah.
That's essentially what CPAP does. It delivers a continuous stream of pressurized air to the non-ventilated lung, helping to keep the airways open and improve gas exchange.
So it's not fully inflating the lung, but it's preventing it from like completely collapsing and keeping those tiny air sacs open?
Exactly. This can be especially helpful in situations where the blood flow to the non-ventilated lung remains higher than we'd like. However, it's important to note that CPAP isn't appropriate in every case.
When wouldn't you use it?
If there's an obstruction in the airway, like a tumor or a blood clot, applying CPAP can actually worsen the situation by forcing air into an already compromised space.
That makes sense. And are there any other situations where CPAP would be a bad idea?
Absolutely. There are times when the surgeon needs the operative lung to remain completely deflated, such as during certain minimally invasive procedures where even a slight inflation could obstruct their view. In those cases, CPAP is off the table.
It's fascinating how much anesthesiologists have to think ahead and anticipate potential issues, constantly adapting their approach based on the, situation.
It's a dynamic environment that requires a deep understanding of physiology, pharmacology, and the surgical procedure itself.
Speaking of pharmacology, there are even medications we can use to fine-tune the process of one lung ventilation.
Now, this is where it gets really interesting. What kind of medications are we talking about? Medications that can, make one lung breathe better. Tell me more. Well, it's not quite as simple as that. But we can use certain medications to optimize blood flow in the lungs during OLV. Remember how we talked about shunting, where blood bypasses the working lung and doesn't pick up oxygen?
Right, like it missed the memo that there's only one lung open for business.
Exactly.
Yeah.
So we can use medications to try and, redirect that blood flow, encouraging more blood to go to the working lung where it can pick up oxygen. Think of it as rerouting traffic around a construction zone.
So you're basically playing traffic cop with the blood vessels in the lungs. That's amazing. How do you even do that?
We can use medications that cause specific blood vessels to constrict, which helps to redirect blood flow. One particularly intriguing approach combines selective pulmonary vasoconstriction, that's the constricting part, with inhaled nitric oxide.
Nitric oxide, isn't that what they use for those tiny babies who have trouble breathing?
The very same. It sounds counterintuitive to use both a vasoconstrictor and a vasodilator, but the idea is to, fine-tune the balance. We constrict the blood vessels in the collapsed lung, reducing blood flow to that area, and then use nitric oxide to dilate the blood vessels in the healthy lung, maximizing blood flow where it's needed most.
So you're essentially creating a two-pronged approach to optimize blood flow and oxygenation during OLV. That's brilliant.
It's a fascinating area of research, especially for patients with pre-existing conditions like pulmonary hypertension, where managing blood flow in the lungs is even more critical. But this kind of targeted therapy highlights how anesthesiology is always evolving. We're constantly seeking new ways to improve patient outcomes, even in procedures that are already considered routine.
It really shows how anesthesiology is a blend of art and science. You're not just putting people to sleep, you're managing complex physiological processes. Speaking of complex, our mock exam scenario threw a real curveball, a sudden hemorrhage during surgery. Talk about pressure.
It's the anesthesiologist's worst nightmare, but also a scenario we train for extensively. In these situations, clear communication, decisive action, and a calm demeanor under pressure are absolutely essential.
It sounds terrifying. What are some of the immediate steps the anesthesiologist would take to stabilize a patient who's hemorrhaging during surgery?
The top priorities are maintaining the patient's blood pressure and ensuring they have enough blood circulating. We need immediate access to the circulatory system, so we establish large-bore 5E lines. Think fire hoses, not garden hoses.
So multiple IVs to deliver fluids and medications as quickly as possible.
Exactly. We're also simultaneously requesting blood products, red blood cells, plasma, platelets, to replace what the patient is losing. In a massive hemorrhage, activating the hospital's massive transfusion protocol is crucial.
Wow, it sounds like a race against time.
It absolutely can be. And throughout all of this, we're constantly monitoring the patient's vital signs, blood pressure, heart rate, oxygen levels, making adjustments to, keep them alive while the surgical team works to control the bleeding. It's a true team effort with everyone playing a critical role.
It's incredible to think about the level of coordination and communication required in those high stakes moments. Everyone has to work together seamlessly.
That's why we train for these scenarios, running through simulations and practicing our responses, so that when the pressure's on, we can act instinctively and effectively.
So the operating room becomes a well-choreographed dance, but with life or death stakes.
You could say that,
Yeah.
but even when the surgery is successfully completed, and the crisis is averted, our job isn't over. Managing pain after these major thoracic surgeries is another crucial aspect of patient care.
Right. Even with minimally invasive techniques, it seems like there's got to be significant pain after, having your chest opened up.
Absolutely.
Mm.
Effective pain management is essential for a smooth recovery. It allows patients to breathe deeply, cough effectively to clear their airways, and move around more comfortably, which helps to prevent complications like pneumonia and blood clots.
And so it's not just about making the patient comfortable, it's about like helping their body heal properly.
Precisely. And we have a range of tools at our disposal, from medications delivered through an epidural, which bathes the nerves around the spinal cord with pain relief, to targeted nerve blocks that numb the surgical area.
What about those erector spina catheters you mentioned earlier? Those seem to be
Where
gaining traction.
these catheters are placed near the erector spina muscles in the back and deliver a continuous infusion of pain medication, providing long-lasting relief. They're particularly effective for managing pain after rib surgery or other procedures where the chest wall is involved.
It's amazing how many different options there are for pain management these days. It seems like the goal is to tailor the approach to the individual patient.
Absolutely. We consider the patient's medical history, the type of surgery they've had, their pain tolerance, and their preferences when creating a pain management plan.
It's incredible how far we've come from the days when open chest surgery was a death sentence. It's a testament to human ingenuity and the dedication of medical professionals who are constantly pushing the boundaries of what's possible.
I completely agree. And as technology continues to advance, who knows what the future holds for thoracic surgery and anesthesia? Perhaps one day we'll have even more sophisticated imaging techniques that allow us to create 3D maps of each patient's airway, making procedures like DLT placement even more precise and predictable.
That's an exciting thought. Imagine a future where something as complex as one lung ventilation is as routine as starting an IV. It really makes you appreciate the incredible skill and dedication of everyone involved in these life-saving procedures. Well, that's about as deep as we can dive today. Thanks for joining us on this fascinating journey into the world of thoracic anesthesia and one lung ventilation. Until next time, keep exploring, keep learning, and never underestimate the power of a deep breath.